Our guest today is Julie Soekoro, Executive Vice President and Chief Financial Officer at Hamilton Healthcare System in Dalton, Georgia. And I want to welcome you for the very first time to our national podcast, Rural Health Today. It is a great pleasure to have you on our podcast today to discuss some exciting information about rural health finance. That does get me a little excited, but rural health finance. And we're taking a lot of hits right now nationally with some of the legislation that's occurred recently, which we'll get into. But Julie, first and foremost, welcome to the podcast. It's great to have you here.
Thank you so much, JJ, and everyone listening. Pleasure to be here. Thank you for inviting me.
Yeah. So, Julie, for our listeners who have not maybe followed your health system, why don't you give our listeners a little background of your where have you been? What have you done? How'd you get in healthcare? How did you get in CFO role? And really, we'll talk a little bit more about what makes it unique.
Sure. Again, thank you for the work that you do, JJ, on the podcast. This is incredibly important for our healthcare systems. Background and role as the senior financial leader for the healthcare system, I have responsibility for overall financial oversight. And I have direct reporting relationships for all things finance, treasury, cash management, AP, payroll, GL, business office, health information management, materials, case management, and IT. I came to Dalton from Birmingham, Alabama, where I was for about 10 years, a little over 6 years ago. So I've been here at Hamilton for about 6 years after deciding to leave the for-profit side of healthcare. Where I had been for 20 years. So that's been an interesting transition. As to why I chose this field, I'd have to say it really chose me. After about 2 years in college, I realized that the salary of a marine biologist doesn't really pay the bills. And I thought, what's the most practical thing I can do? It was engineering or accounting, and I don't like physics. So I chose the accounting route, got my CPA, went to work for a healthcare firm in the Maryland region, and they happen to specialize in healthcare. And that is the long and circuitous route through which I became a CFO. So one of my clients hired me away, one of my audit clients, and it was a lovely not-for-profit hospital in Olney, Maryland, part of the MedStar system now. But I was there for 5 years as a financial analyst and then kind of got off on this crazy CFO track.
Yeah. So do you feel like you're back home again?
I do. I really, when I came to Hamilton, it just felt like home. It was such a welcoming atmosphere, and I thought it's like home again. So yes.
Yeah. So obviously your background, very diverse, and now we're for-profit, now non-for-profit. So welcome back to the poorhouse. A lot of challenges that are facing us. And I'm very excited today to talk a little bit from your perspective. But before we do that, can you give us a sense of the size of your hospital system? What is it comprised of? What does it look like?
Sure, yes. We are a regional healthcare system, but fairly small. We're independent. And we bought out the hospital from the Hospital Authority in, I think it was the mid-90s. We have 2 acute care hospitals. We have 3 nursing homes. We have 3 ASCs, several employed physician practices, a residency program, which we started in 2020, home health, hospice, a children's institute for developmental disabilities, and multiple other affiliates. Pretty much cradle to grave, except for a daycare and a funeral home. Wow. We are across 2 states. We're in Dalton, Georgia, and Cleveland, Tennessee. So the northwest corner of Georgia and southeastern Tennessee. And we serve about 100,000 people in each catchment area and serve several rural counties as part of that. We have a pretty typical mix of government and commercial payers, that you would see elsewhere. And interestingly enough, Dalton is the flooring manufacturing capital of the world.
Oh, wow. Did not know that. So your hospital has how many, would you say, roughly employees, associates?
We have in our healthcare system close to 4,000 associates. We were at about 3,000 until we did the acquisition of the Cleveland facility in August of 2024. And that's been an interesting and fun project. We hadn't done a hospital acquisition previously, but with the nursing homes, which are each about 100 beds,
Oh,
and
nice.
our various affiliates, we have a very interesting sort of microcosm of a healthcare system here. We actually also own half of a payer plan. It's a not-for-profit
Oh, wow.
payer plan, but yeah, so that's kind of interesting. Well, one arm of it is for profit, one arm is not for profit,
Wow.
but mostly on the exchange. So that's my first foray into the payer side of things.
Oh my goodness, that's incredible. So, Julie, that's a little bit about your hospital system. We'll get more into it in just a few minutes, but to humanize this podcast, can you tell us a fun fact about yourself to really
Well,
relate maybe to our listeners?
sure. I grew up in Minnesota and I have lived in 10 states. I have visited
Wow.
49 states.
Oh my.
I spent about 16 years in the DC metropolitan area. So I had
Oh
my share of
wow.
big city living. And I love puzzles, collecting quotes, especially Mark Twain quotes. And I used
Oh
to
yeah.
ride sport bikes. Kind of
Get
gave
out
that
of
up when
here.
I had kids. But
Yeah.
so
So,
that's always
have
something
did
people
you
find weird.
visit Michigan?
I have been to Michigan. I have been through the Upper
Nice.
Peninsula of Michigan.
Yes.
I did my first 2 years at the University of Minnesota in Duluth before I moved to Maryland.
Oh my goodness. Well,
It's
how
beautiful. I
fantastic
came
is that?
across
It
an
is
a moose.
a moose.
It was
Isn't it
scary.
incredible?
He was bigger than
Well,
my
they're
car. He was standing
oh
by the
yeah.
side of the road. I'm telling you, he was bigger than my Toyota Tercel.
Oh yeah. Well, between bears and elk and all those things, it's beautiful, beautiful country land. But it also
Beautiful.
speaks to the rural nature
Yes.
of what we do every
Yes.
day in delivering healthcare in rural communities. And it sounds like with 4,000 employees, you're the economic engine of your communities, which is often what we find in rural, communities.
Well, we would be if we didn't have the flooring companies, Mohawk, Shaw,
Sure.
Engineered Floors, and all of the
Yeah.
supporting companies that assist them.
Yeah.
But so we are one of the larger employers in our
Sure.
community,
Yeah.
um, and so our outreach reaches out to rural counties in our
Right.
markets, and we feel that that is very much an important part of the function that we serve.
Well, good. Well, I look forward to talking a little bit more about that. But, for our listeners today, rural hospitals face very unique challenges in financial sustainability, but serve as irreplaceable roles in our communities. Telling the story effectively will be key to closing the gap between the reality of rural health and how legislators understand the impact of policy. We'll talk about nonprofit healthcare, the challenges of rural health income statements, and of course, what all this has to do with rural health. So let's dive deep into your role as Chief Financial Officer. I'm going to ask you a specific question about what you see as the most significant challenges in rural healthcare right now, especially as they impact and affect financial sustainability.
Well, I really do think it's just managing a bottom line. In order to continue as an ongoing business concern, any entity has to have income that exceeds expenses. And I feel like we are being buffeted from all sides by headwinds. We have never really come down in our costs that inflated during the pandemic. We
Yeah,
did get rid of contract labor. I mean, that was a significant
sure.
portion, but supplies and salaries have stayed elevated. You don't raise the income level for someone and then take it away when the pandemic was
Hmm.
over with.
Hmm.
So higher salaries and wages, higher supply expense without corresponding increases on the net revenue side. So sustained margin compression has definitely
Hmm.
been a factor for us. We
Hmm.
have had, in fact, some of our IT infrastructure vendors have given us triple digit pricing
Oh,
increases. They don't care that we're a
absolutely.
healthcare system. We're needing the same um, technical infrastructure backbone that other industries do as well. And so, we are um, needing to use those same vendors whose stocks are going wild on Wall Street.
Hmm.
So just the market, the margin compression, and then I would say it's very, very difficult to try to sustain a margin when we have the kind of payer pressures that we do. During the pandemic, this is Julie's opinion anyway, my opinion, that the payers were enjoying a period of bringing in premiums and not paying out for services for their
Mm-hmm.
subscribers because everyone was afraid to walk through a cloud of COVID,
Yep.
perception into a hospital. So after the pandemic, since most of the payers are for profits,
Mm-hmm.
they had to sustain their quarterly earnings and
Mm-hmm.
stockholder expectations by continuing to generate good margins. Again, their margin is the difference between what they bring in as a premium and what they pay out to providers. So if they pay out less to providers, there's two ways they can improve their margins: bring in more subscribers, pay out less to
Mm-hmm.
providers. So
Mm-hmm.
we've seen a lot of payer misbehavior at the same time that we are getting pressure on the governmental side of things. It's harder for people to qualify and stay qualified for Medicaid. We
Mm-hmm.
had the one big brutal bill, I'm sorry, HR1,
Yeah.
that came at
Amen.
us. Amen, I know.
Yep.
But, we really, I think, have struggled to tell our story
We
of
have.
these market dynamics that we're struggling with. And at the same time, all hospitals and healthcare systems are trying to expand their market reach to prop up their bottom line. So we have more
Mm-hmm.
intense competition as well.
Mm-hmm. Mm-hmm.
It's just, I think in 30 years of hospital finance, this is probably the most challenging time that I've ever seen in healthcare finance.
I would agree with you. And, I wished I could say it's going to get better. We know it's not. We know that this one ugly bill is certainly going to impact us between now and 2032. But, we have a lot of work ahead of us to ensure the sustainability. And it doesn't matter if you're rural hospitals or major systems. When you look at a rural hospital like Hillsdale, 72% of my payer mix is Medicaid, Medicare. The
Mm-hmm.
government is dictating what I get paid. I'm a price taker, right? We're price takers. And at the end of the day, the challenges are going to be more significant for rural hospitals who are on a very thin margin, at times, no margin. And
Mm-hmm.
when there's no margin, there's no mission. And I know you know
That's
that as a
right.
CFO. And
Yes,
these
100%.
challenges are real. So for your system, Julie, what percentage payers are you looking at, just to give us a perspective? Is it high Medicaid, low Medicaid?
We have probably about 12% Medicaid. We, interestingly enough, have no Medicare Advantage contracts in the Dalton
Hmm.
market. Of course, we inherited some
Wow.
at acquisition when
Yeah.
we bought the Cleveland Hospital, but we have not had a managed care Medicare contract here.
Wow.
And yet they represent probably 35 to 40% of our combined Medicare and Medicare MA
Hmm.
population in this market. So we have probably a little over 50% in Medicare and Medicaid, in Medicare and Medicare Advantage. And then you add on another, 10, 12% for Medicaid.
Hmm.
So we're a little bit lighter on the government side than you are at Hillsdale, it
Hmm.
sounds like.
Hmm.
We have not had a contract with United historically until last year in the Dalton market. We've, of course, been in network with Blue Cross and Cigna and so on. But yeah, it sounds like we are a little more heavily commercial than you are,
Yeah.
and that probably has
Sounds
to
like
do
it.
with
Yeah.
our manufacturing environment.
Yeah. Great advantage that you have when you have manufacturing and industries and your communities. And would you say, was Georgia an expansion state for Medicaid?
No,
They
Georgia
were
was
not.
not an expansion state, and neither was Tennessee.
Oh, wow. Okay.
Hmm.
So
Yeah.
the impact to you really wasn't felt when we expanded, like in Michigan, in other states expanded. You did not have that
Hmm.
impact then.
No.
So
Mm-mm.
what we face now is, it expands. Many, many, many lives are now covered under Medicaid. And
Hmm.
then under the one big beautiful bill, what happens is it cuts back that average commercial rate. And a hospital like mine, by 2032, in implementing in tranches starting in 27, we're going to lose 6 million annually.
It's
And that's
huge.
not even taking into account the ACA and the challenges that we face around the
Hmm.
tax credits. and some of those challenges. So it's becoming, very real about the
Yes.
challenges that we face.
And unfortunately, the ability to cost shift, for years we've operated under negative governmental margins.
Hmm.
And in a way, it's been a little bit like a tax on people who work, quite honestly,
Hmm.
and have
Hmm.
insurance.
Hmm.
But that is the sustainability model that we
Hmm.
have unfortunately um, been accustomed to. So
We have.
I think that it's difficult to embrace some of the types of value based programs, even while they make a lot of sense. Can we really sustain our bottom line with that? Everyone knows the right thing to do is to keep people out of the hospital, but there's no
Hmm.
reimbursement model around that.
Correct. Correct.
It when you have to fund a 24/7 emergency room with thousands and thousands of dollars worth of pharmaceuticals because you never know if someone's going to walk in with a snake bite and
Never
you
know.
need antivenom
Yep.
or you need a clot busting drug or
Yep.
you have to maintain. For us, we have open heart surgery, so we have to maintain call teams. We have to
Hmm.
have the OR standing by. We have all kinds of imaging technology, 24/7 lab. That has to be paid for somehow.
Yeah.
And so if we charge more on the outpatient imaging side to subsidize our inpatient services, that's simply what needs to be done. And when we talk about site
Hmm.
neutrality,
Hmm.
there is a fundamental difference between a healthcare system that is required to be on 24/7 for life-saving care and
Hmm.
an imaging center that can open at 8 in the morning and
That's right.
close at 4 in the afternoon.
That's
So
right.
the entire equation has to work. The math has to work. And that is what
Hmm.
folks fail to acknowledge. I get that it might be frustrating to pay more at a hospital based place. But on the other hand, we've got to fund those acute care services that we're providing.
Hmm. Absolutely. And so, we're going to jump into very, very quickly, we're going to jump into some payer issues and some reimbursement. But before I do that, for the listener today that goes, you know what, JJ, what is the difference between a for profit and a non for profit? Does that just mean you come into more money? That question often gets raised by me. Like, well, how can you be non for profit? What does that mean? For our listeners, could you give us? You've experienced both. You've led both.
Mhm.
I've only been leading in non for profits. So, could you give
Yeah.
us an example of the differences between the two? And then I want to jump into some impact that the payments have had on us.
Sure. Well, I am really grateful for the training that I received while I was on the for-profit side. There's a lot of discipline, operating discipline, and business acumen that I was able to learn. I think there are many, many dedicated individuals providing great patient care in their communities. I worked with some wonderful mentors on the for-profit side, which I am incredibly grateful for. But I think in some ways, it it kind of comes down to reinvesting back in the community. On the on neither side have I felt like there was a glass ceiling for me as a woman
Hmm.
CFO, particularly sometimes as the only woman, in the room.
Hmm.
But so from that perspective, leadership is local,
Hmm.
and even on the for-profit side, I think leadership is local. And I used to say when I was on the for-profit side that the only difference between for-profits and not-for-profits was that for-profits pay taxes. They're
Yeah.
very fond of
Yeah.
saying that, and that made a
Right.
lot of sense to me.
Yeah.
And I remember taking cases from a local not-for-profit competitor that had turned away cases. So I think that it does come down to the local leadership to some degree. But on the other hand, in the end, even though I was at a very high performing hospital, what we produced was never good enough because you're
Hmm.
always trying to feed the stockholder expectations about growth and
Hmm.
increased margins.
Sure.
And I
Sure.
didn't feel good about the long game for my community. I felt like my
Hmm.
community was generating dollars that went to shareholders or the corporate office or maybe even to prop up other hospitals in other markets that weren't doing so well. But I wanted the fruits of my efforts to stay and be reinvested in my community. So
That's right.
ultimately, that's why I left
It's a
the
great
for profit
perspective.
side.
Yeah. Great perspective. And then non for profit. now that you're back into that. Give us some highlights of what qualifies us for non-for-profit and the impact to the community.
It's about the benefit to the community in lieu of paying taxes. What are we doing in terms of charity care? What are we doing in terms of wellness? We actually have a wellness center. We have service lines that we probably wouldn't have if we were a not-for-profit. We are looking at pediatrics, for example. Does it make sense for us to embark on that, even though we know we're going to lose money on it? Is that something that our community needs? And we're working through an ROI. I don't know what that's going to look like down the road, but it puts us in a position where we think about our mission and then we figure out if we can pay for it, rather than automatically tossing out a certain service line because it doesn't have a positive margin. So I do feel that there are things that we do as a not-for-profit that we otherwise wouldn't spend the money on because it's part of our mission to the community.
Right. Right. So we have to have a margin, though, and you would agree with that as a CFO.
We do.
My CFO reminds me of that often. And without a margin, it's hard to carry forward any mission. So there is a balancing act between this.
Very much so.
So Julie, talk to us about, how we're faced with significant operational challenges right now. Cost of labor, cost of material and goods. Even before tariffs were introduced, their vendors were telling us that they're tacking on a this charge for a tariff, and then the challenges post-COVID of a generation that wants to work less for work-family balance, work-life balance, and then also that we're not squeezing out new nurses. We're not seeing new providers. It looks like all of our talent pipelines are just being clogged up. So in light of all of that, looking at operations, looking at workforce efficiencies, patient care, operational growth, and the list goes on and on, how is a hospital system, a rural or larger, going to stay viable today? What recommendations are there?
Well, I think that first of all, we have to stay optimistic. I mean, we all thought we'd be shut down when DRGs came into play, and then APCs, and then we had a pandemic, and we survived all of that. We are remarkably resilient because we have the mission. There's a Margaret Thatcher quote that I love about the Good Samaritan, and she said, "No one would remember the Good Samaritan if he had only good intentions. He had money as well." So he was able to shelter and obtain medical treatment for the person he was trying to help. So we need to remember that if we shut down entirely, we don't offer anything to anybody.
True.
And expectations now in this day and age are even higher than they ever were before. There's instant gratification. There's, wide availability of things that used to be luxury items. So there's a mentality that people have that they want the best, but they don't necessarily want to pay for it. And when you look at all of those things coming together, it's going to take very disciplined operations across the spectrum, thinking out of the box for workforce development, trying to find ways to understand how everything that happens in a hospital has an impact on the bottom line. Employee satisfaction, patient satisfaction, quality. If you always keep the patient first and then mind your blocking and tackling on all of those other things, I feel like you can continue to make a margin. I know it's becoming harder and harder to do that. And so we have to also be very deliberate about putting our message out to the legislators and working with our payers to the extent that we can, because we have to find a way to pay for those increased costs. Everybody wants their piece of the pie. There's a whole lot of profit margin that exists outside the hospital setting between the patient who's getting care and the hospital getting compensated for care. Everybody wants a piece of the pie. And we're going to have to push back against our vendors. It's pretty rare that I don't ask for a discount when we have a renewal. of a
Absolutely.
contract. So always ask for discounts, always ask for more collaboration in those partnerships because we're in this together. If we don't succeed as a healthcare ecosystem, then the device manufacturers don't succeed and the pharmaceutical companies don't succeed. And so we just need to find a way to maybe have a little more equitable distribution of the profit
Hmm.
pie so that
Hmm.
we can afford to prop up the things that we lose money on.
Hmm.
I don't know if I answered your question very well,
You
JJ.
Oh, you did a beautiful job. And I want to segue. One of the points that you raised was about federal legislation. And I really kind of want to end our podcast. We will end it more positive than federal legislation, but we have to tackle it. The
Yes.
impact that the one big beautiful bill and to other decisions in Washington. We have a
Mhm.
saying in rural health: so goes Washington, so goes rural health care, because
Yeah.
the decisions that are made in Washington will either contribute to the sustainability of rural health or it will eliminate. And what we have found since 2010, over 160 hospitals have closed in this country. Scott Becker of Becker Healthcare was just on this podcast. He did some work around what we're facing into the future. His team came up with 735 hospitals at risk of closing over the next several years. These are real
Yeah.
numbers. These are true numbers. They're impacting rural communities because in rural communities, we're the economic engine. The entire community will be devastated. Beyond just the economics is the healthcare outcomes. It's
Yeah.
shutting down obstetrics units. It's shutting
Yeah.
down our psych unit. We have obstetrics still, and we have a psych unit, and we have inpatient behavioral health. We have skilled nursing facility beds, but all of this is at risk at what Congress is doing. Many of these things
Yeah.
are beyond your control as a CFO or mine. So here's a loaded question. In light of what has just happened
Mhm.
across this country, we have been served some very devastating blows.
Mhm.
Right now, 340B is under attack. You
Mhm.
know, right now, low volume adjustment for hospitals like mine could be compromised. Right now, the rollback of the what we would call average commercial rate for Medicaid reimbursement in expansion states, all of that by 2032 goes away. And so, as a CFO, how are you preparing your organization, number one, for these challenges? And number two, what recommendation would you give to other CFOs or CEOs who we hear from all the time, who are on the verge of closing their hospitals because they
Mhm.
don't know what next steps to take? So, what are you doing for your health system to prepare? And what recommendation would you give to other CEOs and CFOs who are
Mhm.
listening to this across the country in preparation of these significant sweeping changes that
Yeah.
are on track to happen?
That's a lot. That's a lot to digest. I think first of all, we have a disconnect in having our story heard by those who are in a position to influence the outcome. We don't have the lobbying dollars that when you're a payer and you can make $2.3 billion a quarter, which is one of our Becker's articles showed a recent for-profit payer um, results for a quarter. You can't compete with that kind of lobbying dollar, right?
Mm-hmm.
On Capitol Hill.
Mm-hmm.
So not only are we consumed with just trying to maintain the viability of our hospitals and pay attention to operations, that's what keeps us busy. We don't have a lot of free time to go schmooze with all the legislators to tell them our
No,
story, nor do we have the dollars. So
right.
we're in a position where it's very challenging to communicate our story. But we also have to remember we have a lot of people that work for us, and together
Mm-hmm.
collectively, we're a loud voice. And I
Mm-hmm.
do
Mm-hmm.
feel that we need to somehow tell the stories to our associates so that our associates, in Hamilton's case, more than 3,500 people are out there telling the story. How do we do that? We haven't figured that out here. I haven't figured that out. And I've struggled with
Mm-hmm.
that very thing. How do we message this to our teammates
Mm-hmm.
so that they
Mm-hmm.
can go out there and message it to their legislators and they can vote with the knowledge that they have, and they can vote for candidates that will move our agendas forward that can connect those dots and look out for rural Americans.
That's right.
When I present the financials to our directors and I talk about something that's coming at us, whether it's, hey, we might not make our dish percentage this year to get our 340B dollars, you need to go talk to your legislators about that. I want every one of you to make a phone call or an email or a letter to your legislators and continue those grassroots efforts, because literally, we're just trying to keep the hospitals running. And there's no silver bullet. You have to have operating discipline, and we're going to have to learn to say no. And we don't want to say no. You don't want to say no to obstetrics. You don't want to say no to behavioral health, because those are critical services. But something's got to give if you're also going to try to treat that patient that's coming in with a heart attack or that's just been, in a car accident. So, continuing our story, connecting the dots for our legislators, connecting the dots for our associates. I personally need to learn how to do a better job of that. I try to tell this story to our directors, and it's usually when I've been faced with some kind of legislative impact. This is what site neutrality will mean to us. This is what 340B loss will mean to us. This is what the one big brutal bill is going to mean to us. If we lose our DPP programs, there's going to be significant cuts, and it's going to impact everyone on our teams. So I don't have a magic bullet. How are we preparing? I think before one big brutal bill gets to us, in terms of the timing of things, we need to start doing more around financial resiliency to the extent that we can. We may not have been as tight around management of capital in the past as we need to be in the future, but we need to understand the ROI on everything, the return on investment for all of our expenditures. And if it's not there, we might still go forward with that project, but we'll do so with the knowledge that, hey, we're going to be doing this even though we're going to lose money on it.
Yeah. So those are the opportunities, to hunker down and to prepare. And I think in boardrooms across the country, that is going on right now. And, the success and the sustainability of a resilient board is only as equal and important as us in our industry and our patients telling our story. And I think one of the things that I did early on, I remember it very distinctively, when I started to hear about the big bill that was being proposed. I came into the studio and I did a 20-minute video to all of my staff, and I went live. From that video, it was leaked to our congressman, and he sent me a text message that was very nasty and very negative. A friend of mine who I have been on his campaign and ran his campaigns locally. And unfortunately, we got ahead of their narrative by saying that this will hurt our community. And he received a tremendous amount of backlash for voting for that bill. And we empowered our staff, the salt of the earth people, to tell their story. And I think we need to do more of that. There needs to be more of that advocacy. And so we're starting to see the
preparation. And I'm sorry.
No, go ahead.
Yeah, it takes time and preparation to put those messages together, though. You have to craft them very carefully. And when you've got doctors hollering at you about the humidity in the OR and they can't do cases, which problem are you going to deal with?
That's right. As of today, responding to critical incidents at your hospital. And it's now, the time we get out of here. Last night was 8:30 that I left. And not too many congressional leaders or representatives are going to take my call at 9 o'clock at night, as you're simply exhausted. So the opportunity to surround yourself in have the advocacy and the voice of all of our employees is so critically important. And I think that's the only thing that's going to help us change that. So, Julie, we didn't even get into price transparency. We didn't get into half these things, that I so wanted to talk about today. But I'd love to have you back on the podcast. You did a fantastic job outlining from a CFO's perspective, the financial challenges, and then, put your people in the mix. How are we recruiting talent? That's a whole nother conversation. And then operations, how are we attracting new business? and sustainable models and reducing costs. There's so many players. We call
So
it the
many
pillars here. There's so many. But I
So
want to have
many
you
things
back
to talk
on.
about. Yeah. Oh, I'd love to. It would be fun. I think we've had a lot of success with our workforce here.
I
We
want to
have
talk about
some
that.
extremely talented HR leadership that
Good.
I think has thought outside the box, and we've done really well with that. We have great low turnover numbers and good retention numbers,
Wow.
and so yeah, we'd love to share that message.
I would love to hear that message because across, my fellow colleagues are sharing war stories about open positions that have been open for 2 or 3 years since COVID,
Yeah.
double-digit turnover rates. And that turnover costs, we can talk about it at that time. But I'd love to have you back on just for that conversation if we could.
Sure, happy to.
Awesome.
I'll
Before we
probably
wrap up,
bring along our VP of HR. She's
let's do
extremely
it.
talented.
Let's absolutely do that. And again, the opportunity for us is to share best practices for other hospital systems who are struggling that are listening to this podcast to say, how can we make it in today's environment? And there are ways to do it. I want to give encouragement. I get charged up ready to charge hell with a squirt gun every day that I come to work, just excited about the opportunity to serve our community. And every battle, every fight we have is with purpose, and it needs to be with passion and for cause that we're taking care of our community.
It's a calling.
It is a calling. It really is. It's a ministry. So we'd like to wrap up today with our closing segment. It's called Rural Health Recommendations. And it's a reminder for every guest that we have on the show. We ask them to contribute a recommendation on rural life and healthcare. It can be a tip of someone new working in healthcare as a new leader, maybe someone that is in need of sage advice because they are going through this most tumultuous experience called the federal government's cuts. And it doesn't always have to be rural setting, but would you give us one sage piece of advice for a new leader out there who's struggling today? And we're going to add this to our recommendation on the website, ruralhealthtoday.com. So what would be your rural health recommendation for our audience today?
JJ, I think that it's really important for all of our leaders to get involved in advocacy for our organizations, regardless of how busy we are. We need to be able to message what we're going through and have a grassroots effort around that. Margaret Mead had a great quote. You've probably used it multiple times on your podcast, but she said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has."
Incredible.
So keep up the hope that we will prevail as well.
There is a hope, and we have to dig deep sometimes to find that hope, but it does exist, and it exists in the faces of the patients that walk through our front door every day that need us, and that is the point of the mission. So thanks for what you're doing in your states, because you're in 2 states. Thank you for the work that you've done in decades past of working in healthcare, and for the work that you do right now. Every time you lift your voice, Julie, you're lifting your voice for all of us. So when you get the ear of your congressional leaders or representatives, you're lifting our voice, and I want to thank you for doing that as well.
And thank you for the same thing, JJ.
Absolutely. And thanks to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of healthcare every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.